Good afternoon. My name is Dong Kim, and I am going to be talking to you about a specific type of brain tumor called a meningioma. Many of you may have that diagnosis or have heard of it already, and it has features and treatments that are very different. This is the outline of what we're going to be talking about today, and this is really for patients. So I want to go over what a meningioma is, who's at risk, why some people get it, the treatment options, and the prognosis. So hopefully this will be helpful to you. So first, before I talk about meningiomas, I need to go over a little anatomy. This is a picture of a cross-section of part of our head and skull and brain. So in this schematic, if you look here, this is the scalp, this is the bone, and this is the brain. Now the important thing to understand is that the brain is bathed in this clear fluid called cerebrospinal fluid, and as a result there is a membrane that completely surrounds our brain and invests it. There are layers to this membrane, but as a group, that membrane is called the Meninges. And that word is the root for many medical terms. So if that membrane gets inflamed or infected, we call that meningitis. And as you'll find out, meningiomas come from that membrane, and that's why they're called meningiomas. Now there's another feature here I want you to look at, because this will come up later. This membrane here, really officially called the dura, splits, and within the folds of the membrane, or the dura, there are veins or channels for which venous blood runs, and they're officially called sinuses. And this is going to be important for us when we consider treatment. The dura is one of the meninges, and it's a Latin word. The official full name for it is called dura mater, which really means tough mother in Latin. And the anatomist saw this as a very firm membrane, which it is, and gave it that name. So what is a meningioma? A meningioma arises from the lining of the brain, that is the meninges. There's a specific type of cell within those meninges that give rise to the meningioma, but we don't need to go into that level of detail. All tumors or growths, what we call neoplasms, arise because cells grow continuously and don't stop. So in our whole body, let's take our skin as an example, there's a real balance between cells that divide and grow and cells that die, so that our skin is being replenished, but there isn't a growth or tumor that's growing continuously. When specific cells continue to grow and divide and don't respond to signals to stop, that's when tumors such as meningiomas occur. That happens because of DNA injury. DNA injury could be the result of something external, like smoking or exposure to radiation. But even if we had no such exposure, we have mutations that happen at different places in our DNA all over our body. And if that mutation happens in the wrong gene or part of the DNA, and then the cell starts to grow out of control, that can be the cause of the tumor. In fact, that is most often the cause. And when the tumor can spread, then we call that cancer. So most tumors and cancer are the result of DNA changes that happen. Specifically for a meningioma, when they grow on the meninges, and because there's bone on the other side, as we just saw, they grow towards the brain. And that gives a characteristic MRI or CT appearance, which we'll see soon. And the way we make the diagnosis is usually on MRI or CT. When we remove the tumor or biopsy it and send it to the pathologist, they grade it on a system that was designated by the World Health Organization. So all brain tumors are graded on a 1 to 4 scale, and the higher the number, the worse the outcome or the more aggressive the tumor. And a meningioma that's a grade 1 is the best type of meningioma. Fortunately, almost 90% of meningiomas are grade 1s. Then grade 2s are considered transitional, and then grade 3s are considered malignant. So this is a picture of a meningioma. This is a cross-section just like the anatomy slide we saw before. So here's the scalp. The bone is showing up here, and you can see the dura right there. And arising from the dura is this tumor. This is a very characteristic appearance for meningioma. It's arising from the meninges, it's pushing into the brain. You can see the brain here has a little swelling as a result, and this part of the brain should be right along the skull, just like the other side. And that pressure can cause symptoms that we'll talk about later. But when we see a tumor that looks like this, that's attached to the dura, then more often than not, it is a meningioma. And the best way to diagnose it is with this kind of scan. Meningiomas can arise anywhere in the brain that has dura. It can be behind the eyes, it can be around a part called the brainstem. Most often it's up in this area, but the treatment of the meningioma is often quite dependent on the location. And because our brain function is localized, that means different parts of our brain does different things, the patients will have different symptoms based on where the meningioma is. For example, a patient with a meningioma here may experience numbness or weakness because the movement and sensory parts of our brain are here. A patient with a meningioma here may lose a sense of smell, and so on. This is a coordination center, and the patient may have difficulty with writing or walking. And so the location of the meningioma and the size is going to have a lot to do with the presentation or the symptoms that patients get. So here are some facts. It's the most common primary brain tumor in the brain. A primary brain tumor means that it started in the brain itself, not somewhere else. There are also what we call secondary tumors or metastatic tumors, and for example, that might be somebody with lung cancer where tumors have spread to the brain. But when we look at the primary tumors, meningiomas are the most common. It accounts for 1 in 3 of all primary brain tumors diagnosed in the United States, and the risk increases with age. For every 3 patients with a meningioma, 2 are women and 1 are men, and African Americans may have the highest risk. So what are some of the risk factors? There are some definite known risk factors, and the largest one is radiation to the scalp. We know this for 2 reasons. One, there were atomic bomb survivors, and they do clearly have a 6 to 10-fold higher risk of developing a meningioma. And there was a time when children with scalp ringworm were treated using radiation. This happened in Israel for about a decade, and those children were followed as they became adults, and it became clear that the meningioma development in this group of treated children was 10 times higher than in the general population. So that is the highest risk, is if you get radiation. This is not the kind of radiation you get from a chest x-ray or tanning in the sun. This is ionizing radiation, and does confer risk, but it's not something most of us are exposed to. There's a lot of theorizing and evidence that maybe estrogens have an effect on meningiomas. One of the reasons for that is that women get meningiomas more than men, and also the tumors themselves often have estrogen receptors. What we don't know is that whether using estrogen, such as women going through menopause, whether that increases risk or not. There are many studies that have had different results, but what that usually means is if there is a risk, it will be small, although it's unclear at this point, and I don't think it should be a significant concern. There's been a lot of talk about cell phone use and brain tumors of all kinds. At this point, there have been studies looking at many, many patients, some in the tens of thousands. And again, while nothing is conclusive, what that means is this is not likely to be a significant risk. And I use my cell phone for about 2 hours a day, and I, don't think you have to worry too much about that and getting a brain tumor at this point. What about the type of work you might do, what you might eat, whether you have allergies? As far as we know, there is no association between that. There are some people who have had family members with meningiomas, and there are also some genetic conditions, like a word that you might hear is neurofibromatosis, a type of that, where those family members get more meningiomas. But if you were in such a family, you would know it, because that comes with a host of different characteristics. But if you had a father or a sister or a brother who has a meningioma, then you might have a slightly higher risk, maybe a twofold increase, but not much more than that. And your risk of getting a meningioma is quite low to begin with, so a twofold increase does not mean that you are likely to get it yourself. We do know that that in the cohort of patients, if you take all the patients with breast cancer and compare them to the general population, they're probably at about twofold higher risk for getting a meningioma also. Whether that same genetic defect that can cause breast cancers, particularly a gene called BRCA1, may also increase the risk for meningioma, it's possible, although not entirely known. So those are some of the risks. So why did you get this meningioma if you happen to be a patient? I can tell you in general, unless you've had something specific like radiation treatment to your head, this is largely bad luck. As we go through life, we're all at risk for developing this disease or that disease, from heart disease to tumors to meningiomas. And as people, we often want to look back and say, I did this or I did that, and that's what caused this. And sometimes it's just a random mutation that happened and nothing you could have controlled. And certainly, unlike the very clear link between smoking and lung cancer, there is really no significant behavioral thing that we know that made you more likely to get a meningioma than somebody else. So what symptoms can result? Well, as a meningioma gets larger, it takes up space within the skull, which is a fixed space because the skull is bone, and that pressure and the pressure on the brain can cause headaches. That's a very common presenting symptom. Also, because of that pressure on the brain, a patient can suffer a seizure. Usually, before somebody starts to have actual changes in their neurological status, the patient will have a headache first, but not always. And depending on where the meningioma is, the changes can be anything from subtle memory loss to personality changes in an elderly patient where their family is just saying, oh, mom's getting older, or maybe she has Alzheimer's, to something more specific like weakness or numbness on one side of the body, or vision loss or hearing loss. It really depends on the size and the location of the tumor. If the tumor is near a very critical and specific functioning structure, let's say the nerve that comes from your eyeball to the brain, which we call the optic nerve, a very small tumor pressing on that nerve can cause loss of vision or changes in vision. and then we'll pick it up that way. But if the tumor is away from any nerves like that, and it's just pushing on the brain itself, it can get to be quite large before it produces symptoms. So because the functions of the brain are localized, where the tumor is very important for determining what the presentation is. So what about asymptomatic meningiomas? This is going to be an important topic, and some of you may have this. What that means is you had an MRI or CT for another reason. You had a TIA, or you were in a car accident, and somebody wanted to make sure you didn't have any brain injury. And in fact, what the scan shows is not what the doctor might have been worried about, but a meningioma. Usually these are smaller and more favorable, and for you to be having, or for a patient to have an asymptomatic meningioma, it means that when I examine them, they're normal. When you talk to their family, they say, you know, Dad hasn't changed at all, and you say, I don't have headaches or anything, I feel great. I would never have known something was going on. And that we call an asymptomatic status. They're usually smaller tumors. They're often in more favorable locations, and this is a very important consideration in whether we treat or not. So what are we going to do about my meningioma? So let's start with the asymptomatic, since we just talked about that. We do know that many meningiomas grow to a certain size and then stop growing. We don't know exactly why, but if we took 100 asymptomatic patients and just follow them all for a year, let's say we didn't do anything, and a year later we got another MRI scan, probably 65 of those patients would have the exact same size tumor as the year before. But 35 of those patients will have shown an increase, which means the tumor is continuing to grow. If a tumor is stable and not growing, they can be observed. But for me, observation means one MRI or CT every year, because there are some meningiomas that can be stable for a while and then can start growing again. The other options, even if it's asymptomatic, is to treat it, and we're going to talk more about this. The treatment consists largely of surgery or some type of radiation or a combination. And this really depends on the age and health of the patient and the emotional response of the patient. Some patients, don't like the idea of having a tumor and want to treat it no matter what. If you're young and let's say you're 25 years old, it's much more likely that sooner or later we're going to have to treat this tumor than if you were 85 years old. And so all of those kind of factors go into consideration. But it's clear that if the meningioma is truly asymptomatic, the best option may be to do nothing. And if that's the case, I usually recommend the first follow-up scan at 6 months, and if that's stable, once a year going forward. But here's a thing that I feel is very important. If you and your doctor decide to observe the tumor, you have to observe the tumor. You can't forget about it. And this is a patient, she was 79 when I saw her. When she was 68, 11 years ago, she had a little trouble hearing and some ringing in her ear, and ended up having a scan and was noted to have a very small meningioma. It was about 1/10 of the size it is now. And if you look at this MRI scan, this is a different kind of sectional view. This is what we call an axial view. These are the eyes. This is the nose. These are the earlobes. And this is the meningioma growing into what we call the brainstem and cerebellum. At that time, she and her neurosurgeon decided we're not going to do anything, and that was a good plan, except that the doctor's office didn't call to schedule the follow-up, and the patient forgot about it. And then over the last several years, she's had significant problems from this meningioma, including headaches, and then recently stumbling gait. And when I saw her, it was much bigger and needed to be treated. So I feel like this is very important. If you are going to observe the meningioma and you're the patient, make sure you're getting yearly studies. So what if it's a symptomatic meningioma? Well, most of the time we will treat that tumor. And there are two options, and I can talk to you about both. First is surgery, where we actually go in and remove the tumor. All meningiomas, or most meningiomas, are in good locations, many, because, as you saw from the pictures below that I showed you earlier, the meningiomas are right under your skull, between your skull and the brain. So when it's on the surface of the brain, we don't have to go through normal brain tissue to remove the meningioma. How safely we can remove it depends on whether it's stuck on the brain or comes off very easily without any kind of dissection necessary, and that often has to do with how big the tumor is and if there's any nerves, such as vision nerves, nearby. Surgery is the only treatment that can just go in and remove the tumor and take the mass away. So if a lot of the symptoms are from the large size of the tumor itself, then surgery is often a good option. But of course, surgery has risks like everything, and a major consideration is the age and the medical condition of the patient, because most of the time this has to be done under general anesthesia. Also, the location of the tumor is, again, very important. Some tumors are in difficult to reach locations, but usually the biggest problem for us as surgeons is if the tumor wraps around or is very attached to some of the nerves that emanate from our brain. For example, the nerve that we see with, but also nerves like nerves that move our eye or move our face. And when you have to peel the tumor off the nerve, often the nerve will stop functioning, at least temporarily, sometimes permanently, and this can cause a deficit. So a lot of my thinking about who should have surgery or not depends on the location. And in some areas, as I'll explain, we cannot remove the entire tumor. What about radiation? Well, radiation works by cutting the DNA of the tumor itself and the surrounding tissue if it gets a significant radiation dose. I told you earlier that these tumors arise as a result of DNA injury, but if you use focused radiation and cut a lot of the DNA in the cells, then the cells cannot divide and grow. And that's because for us to go from one cell to two cells, that's the normal division and growth, that cell has to replicate or recreate all the DNA that was existing in the first cell. It's called DNA synthesis, and that cannot happen if the DNA is chopped up. And that's how radiation works. That's why a small dose of radiation can lead to tumor growth, because the radiation is also affecting the DNA. The tumor cells then do not die with radiation treatments. They just become quiescent and they stop growing. Sometimes they shrink a little bit, but usually they stay about the same size, and so they're just going to remain there. An issue is that the mass effect doesn't change very much, but radiation is very effective treatment, especially for grade 1 meningiomas. And the follow-up is usually we follow patients for 10 years, and the rate of the tumor being stable during that time is very high, on the order of over 90%. A major advantage of radiation is that no surgery is required, which is a lot harder for patients to go through, and the risk of developing a deficit such as a drooping face is much less, particularly for some locations. Of course, one of the questions that often comes up is, if I get this radiation treatment, am I at higher risk for developing another tumor later? And as I showed you earlier, any radiation treatment does increase the risk, so that does have to be taken into account. But again, that risk is not really high. And the risk of injury to surrounding tissues is often less. There are two types of radiation, and I'm mainly going to talk about gamma knife radiosurgery because we use that the most. But standard radiation is the type that people get when they get cancer treatment. You go once a day, 5 days a week for a few weeks, and a single beam of radiation is targeted to a certain area of your body. We don't do that as much anymore because we have the gamma knife, which is a much more focused one-day outpatient procedure, and I'll be talking to you about that with the next slide. But before we get to that, I do want to mention that at this point, chemotherapy has no role, and the reason for that is that we do not have any chemotherapeutic agents at this point that has been shown or proven to have good effects on meningioma patients. So it's really surgery and radiation, and I will go over with case examples how we decide which treatment to do. So unlike the standard radiation, when we look at the gamma knife, we see we have 201 radiation sources, and that's represented by these little balls. And they're arrayed around this, what we call the collimator, and all around. And this radiation is then put into a long tube in the collimator so it becomes a beam. The patient is positioned inside this collimator, and then with a frame using the MRI system, we can target these beams just to the tumor itself and not to the surrounding tissue. So the tumor gets a large radiation dose, but not the surrounding tissue. The standard radiation, which we use much less often because it's not as good, is one beam of radiation going through all the tissues. So that's why you have to have many small treatments, because your scalp and skin and brain is getting a similar dose as your tumor. For the gamma knife, the tumor gets a big dose, but the surrounding tissues get very little dose. So very good technology. And this is a computer image of our actual target with a gamma knife. To do that, we put a frame on the patient, and the patient gets the MRI with the frame on. And by moving the frame in space and using these computer visualization techniques, we can point the gamma rays right at the tumor. It goes further than that, however, by adjusting which holes are open and which ones are closed, and by the positioning, the radiation can be made conformal. What that means is that the radiation can be contoured around the tumors, not just a solid circle, so that even in a dumbbell-shaped or oblong-shaped tumor like this is a meningioma that's arising from the dura here, we can target it so precisely. You can see the yellow line is the main target, and then the green line is a surrounding area that gets very small dose of radiation, but not a big dose. That's why the gamma knife has become such a effective and preferred method of radiation delivery. Our gamma knife was only the 12th installed in the entire United States. That was back in, I think, 1994. It was the first one installed in the Texas Medical Center here, and we've treated more than 2,000 patients in our gamma knife. About a year and a half ago, we put in the latest model, which is called the Perfection. This is a picture of it. And if you have had or will have gamma knife treatment, you're awake through the entire procedure. There's no anesthesia. It's not painful. You lay on this bed, your head in the reference frame, which is fixed so you can't move, sits comfortably, and then the doors open, the bed slides in. You can sit there in there for anywhere from 15 minutes to an hour and a half, 2 hours, depending on the size of the tumor, and then you come out. The frame goes out, and typically our patients for this come in at 5:30 in the morning, and they're home by 2 or 3 o'clock in the afternoon. So it's a very good technology. So let's start looking at some examples. This is a patient of mine, 34 years old only, very healthy, was not having any problems until out of the blue he had a seizure. Very frightening event. You can see his meningioma here. This is the example I showed you earlier. You can see this was the brain area that probably where the seizure emanated from. And you can see that this is the area of the dura. It's even thicker where all the tumor cells are sitting. He's a young man, he's healthy. There's no reason not to remove this tumor. So I make an incision over the scalp in this area. We do what's called a craniotomy, which is a flap of bone that's removed temporarily. And sometimes for meningiomas, we remove the bone and keep it out because some of the tumor cells can go into the bone. Then if you cut the dura or the meninges in a circle around the tumor, all the way around, then there's nothing attaching the tumor to the brain anymore. If there is a good plane here, which means this is not attached, then this tumor virtually lifts off, and then the brain pressure is gone, what we call mass effect, and the brain can slowly start to come out. And with that pressure gone, often the patients will no longer suffer seizures. We either replace the bone, or if the bone was removed, because I'm concerned that there's tumor cells in there, then we can reconstruct this part of the skull nowadays using titanium implants or plastic implants or bone putty. And then the patient will have no cosmetic deficit. And this was a simple surgery, usually 2 days in the hospital. And this patient should be completely cured. I still recommend a yearly follow-up because they can come back, but this patient should be cured of his meningioma. Here's another patient that looks like they have a similar looking meningioma, but there is a big difference. This is a 54-year-old man. He did not have a seizure, but he had what he called funny feelings on the left side of his body. Tingling, feelings of numbness. And then over time, he began to get very subtle weakness, particularly in his left hand. This led to an evaluation, and what we see here is also a meningioma, also based on the dura. The bone overlying it is a little more abnormal, but this tumor is growing right on the sinus, or the venous channel that I told you about before. This leaf of dura is the wall of the sinus, and the tumor cells have invaded into that wall. For this patient, I cannot get a complete tumor resection safely, because if we were to resect this sinus, which is flowing with venous blood, that could have severe consequences for the brain. And it can lead to a type of stroke from inadequate venous flow. But this patient is also suffering from significant mass effect, and I want to take that mass out. So in this case, we do a debulking where I was able to shave the tumor off right here, leaving a little remnant on the wall of the sinus, but removing all of this mass here. So something like about a 95% reduction in volume. That took away the mass effect. The patient returned to normal, but now I knew that there was a little bit of tumor left. We followed that for a short period of time, about 6 months, and during that period, that little nubbin clearly started to show an increase in size. And what we did was we then targeted the residual using the gamma knife and gave that radiation. And then the patient felt better, and the tumor stopped growing. What about doing the radiation right off the bat, the gamma knife? Well, in this case, that's not a good option because this is a little technical, but if the tumor gets too big, the radiation cannot be given safely. And the limit for that is about a 3-centimeter sized tumor, and this is approaching that. On top of which, this patient was having symptoms, and so I wanted to alleviate those symptoms. So this is a combination. You're going to hear that we use that a lot nowadays to treat meningiomas. Next is a completely asymptomatic, incidentally discovered meningioma. This is a 76-year-old that presented with what we call a transient ischemic attack. She and suddenly lost her vision in her right eye for 2 or 3 minutes. It just blacked out and then came back. And then she got various scans, and in fact what we see is this. This is a tiny meningioma. You can see that. And this is a different view of the same tumor. And because this was asymptomatic, this is a patient we're going to observe. So small, this is an easy case for gamma knife too, but there's no reason to put somebody through a radiation treatment unless we know this tumor is growing. We've got to remember not to forget, and so at intervals we'll check, and as long as that tumor stays the same, she will not need any treatment at all. Here's another incidentally discovered meningioma. This is a 37-year-old that started having headaches after a mild head injury, a snowboarding injury, a bad concussion, and had headaches for several weeks. We found this little meningioma. This is part of our Meninges too, and here's the tumor. And when I saw the patient, I told the patient that he was an asymptomatic meningioma. This tumor is too small to be producing headaches in patients, and after a concussion, it's quite common to have the kind of headaches that he was experiencing. So I do not think that this tumor was causing anything. We just happened to pick it up because there was an accident. Now this patient is only 37 years old. So do we need to do something about it now or not? You know, there are 3 good options for this patient. 1, we can just observe it, and that's what we decided to do. 2, there are some people who would say, well, I'm young and healthy, and if you think the surgery is safe, let's just go ahead and remove it. And the surgery is very safe. This is well away from the sinus, which is up here. There's no nerves in this area. I can easily go and remove not only the tumor, but the dura that it's attached to, and this should be a curative operation. There are some arteries here that sometimes of concern when they get large, but that's not involved. But the patient still has to go through surgery. The third option is to do gamma knife. This is an ideal case for that too. So in some instances, all the options are good, and it's something we can decide together with me and the patient. And here we decided to just observe it. Here's another tumor, though. This is a tiny tumor, but this patient presented with vision loss. Now this is a different view of the head and brain. It's called the sagittal section. So this is the top of the head, the back of the head, the nose, and the mouth is here. You can see our brain here. This is our vision apparatus coming from the eyeball, which is over here, more on the side. And as the optic nerves or our vision nerves come back, right next to it developed this little meningioma. It was tiny, only a centimeter. And the patient was 45 years old, but she was beginning to lose vision in that eye. For this patient, the only option is surgery. The optic nerves are particularly sensitive to radiation, and we cannot do gamma knife even for a very small tumor if it is next to the optic nerve. So to help her, and even though it was small, I didn't want to observe this tumor because it was entirely possible she could become blind in that right eye over time. So she went to surgery. I was able to remove this tumor, peel it off the optic nerve very safely. There's usually a very good plane, which means these tumors are not stuck to the surrounding brain structures. And then within a few weeks after her surgery, her vision was normal. Now, we'll also be following this patient too, but hopefully it will not recur. Few more examples, and then we'll get to some questions. This is a 79-year-old that presented with memory changes, emotional flatness, was having headaches. She was diagnosed, frankly, with Alzheimer's disease. She was in a nursing home, and then she ended up getting a scan. And you can see this enormous tumor. This is arising from the front part of our brain. Our frontal lobes are very involved in our cognition and memory and personality. And this meningioma arose off of the area where our smelling nerves come to. This is a harder situation for me as a surgeon. You know, she's older. The results of the surgery are not as good, but on the other hand, this is a patient that could get dramatically better. May not have dementia at all. It's just a large tumor pressing on it. This is also too big for Gamma Knife. So she went to surgery. One of the things that I tested beforehand, because she wasn't complaining about it, was her sense of smell. She had already lost a sense of smell. And if somebody has smell, I try hard to preserve it during surgery. And the reason for that is that smell itself isn't so important, but most of what we consider to be taste is actually smell. So if you've known anybody who's lost their sense of smell, what they really complain about is that everything tastes like cardboard. She was having so many cognitive issues that she didn't even think to tell anybody that her smell had gone or her taste. And she had a pretty long recovery period. You know, at that age with a big surgery, you don't bounce back right away. But 3 months later, she was much better than she was before the surgery. And as one of her daughters said, it was like having her mother back. So there can be dramatic improvements with very large meningiomas. And it also goes to show you that because these are slow-growing tumors and changes can happen over many years, it can get to be enormous and cause very significant problems, and a diagnosis may be missed. Finally, final case example is this is a very difficult tumor. This is a patient that is only a 42-year-old African-American woman, lovely woman, who presented with declining vision in both eyes. It started with loss of peripheral vision, and by the time I saw her, she was having significant vision problems. And this is a meningioma too, but it's in one of the worst locations for us. It's right in front of the brainstem. This is all the brainstem. The reason she was going blind is because the optic nerves and chiasm, like that other patient, was here and is being pushed by this nerve. But this nerve is also around a lot of nerves that move her eye, that move her face, that help her swallow down low. And for us to go and remove this tumor entirely is possible, but has a significant risk for causing a lot of problems for patients. It can not only be cosmetic problems like a facial droop, but if you can't swallow, then you need a feeding tube put in, even if it's temporary. If you have significant double vision, those are very problematic consequences. On the other hand, this tumor was rather big, and I couldn't radiate anything up here because of the optic nerves. She was also having headaches, so my approach was to primarily concentrate on decompressing her optic nerves first, which I felt could be done safely, remove enough of the tumor to be able to do Gamma Knife on the remnant, and yet not so much tumor she had a lot of deficits. And so that was the approach I took. Even with that more conservative approach, she woke up from surgery with what we call a third nerve palsy, where her right eyeball was not moving as well. And for about 3 months, she had significant double vision and had to wear an eye patch. On the other hand, her vision improved dramatically, and then the third nerve palsy did resolve. She did not have any other significant palsies, and then we did go ahead with the Gamma Knife treatment. So again, a combination, and depending on where the tumor is, the treatment will vary. So finally, what's going to happen to you even after treatment? Most meningiomas can recur. There are some areas like that patient I showed you where I have a lot of confidence that it won't, but it's not a guarantee. Or if we're watching it, they can grow, or it can grow even after radiation. So I do annual scans on every one of my patients with meningiomas, and I have, several hundred patients that I'm following in this way. Many can be cured, but even if it cannot be cured, which means the tumor is gone and there's no more cells left that are abnormal, most of these can be managed, but not all. Even for what we call a benign tumor, sometimes they can grow after radiation, and those become big problems. But for most people and most patients, they can be managed very effectively. The prognosis is very good, and particularly for grade 1 tumors. And I think we went over some of the things that we think about for meningiomas. So thank you for your attention, and we have a few minutes, and I'll see if I can answer some questions. So here's the first question from Frank. Any likelihood that during follow-up that a benign tumor will become malignant? That is possible with the meningiomas, but it is very uncommon. And highly malignant meningiomas we do not see very often. And it's too technical for me to go into all the features, but often on the MRI scan I can tell if a tumor is going to be malignant. But it can happen in a very low percentage of patients. Even after treatment, though, a tumor can become malignant, and so that's another reason for follow-up. But the odds of that happening are low. So here's another question from Kelly. She has what she describes as a parasagittal sinus meningioma with midline shift, a 4 by 4 centimeter tumor, and the patient is 50 years old. You know, Kelly, if you're a healthy 50-year-old, for a tumor this size, my recommendation is removing it. You don't say whether you're having symptoms or not, but it's highly unlikely that you're not having any symptoms, such as a headache with a tumor this big. And a parasagittal sinus meningioma is exactly that tumor I showed you earlier that is growing into the vein in the middle. And so most of that can be removed, and then you should feel much better afterwards. Here's a question from Jamie. Do you recommend MRI as a means to early detect tumors? I would say no. Even for myself and my family, we don't routinely get scans because the chances of finding something like a meningioma is so low that I don't think a surveillance scan would be important for the majority of us. And then we would have to scan so many people to find a few that is not a good option. Here's a question from Carol. We are doing MRIs every 3 months right now. I am 48 years old. And, you know, it depends on your tumor and the size and the circumstances. It's hard for me to just say whether that's a good thing or a bad thing. In general, I have no objection to doing scans more frequently. But if the first 1 or 2 scans at 3 months doesn't show anything, then that interval can be increased. There's no reason to keep doing it every 3 months for 3 or 4 years in a row because, as I said earlier, some of these don't grow at all, and some, you know, even if they do grow, can occur very slowly. Now, Janice asked the questions, are there any common symptoms that indicate a recurrence of the meningioma? Well, that's a good question, too. I probably should have thought about putting that in the presentation. The meningiomas all recur at or near where the original tumor was. So these are not tumors that can metastasize or go to your lung or your liver, so we don't have to do body scans. And if they recur, they're going to recur locally. So that means if the tumor has gotten as big as it was before surgery, or gotten bigger before radiation, then you might have the same symptom or a progression of symptoms. But usually when we use the gamma knife or we operate on patients, after the treatment, all of those initial symptoms are gone. We also get annual surveillance scans, so whenever we do pick up a recurrence, it's usually quite small, and so are not symptomatic at all. And most of the time when we pick up a recurrence later, we use a gamma knife to treat it. It's less common to have to go and do a repeat operation. This is probably going to be our last question. My mom is 75. My mom is 75 and has stage 4 lung cancer with brain mets, about 7, and meningiomas, small ones. Can this be treated with cyber or gamma knife? This is a little bit off the topic, but we treat a lot of brain metastases with gamma knife now. In fact, we used to do what's called whole brain radiation for those patients, and that has a lot of devastating cognitive consequences. Many of those patients end up developing dementia, and even if it's 7 or 12 or 15, we can target them with a gamma knife. They're just in the machine longer, and what that means is that the tumors can be targeted, but the surrounding brain doesn't get the same kind of radiation, so the patients do better. If somebody has stage 4 lung cancer and they're in the gamma knife anyway, and there are small meningiomas along with the brain mets, I would probably treat it, and the reason for this is that we can't tell with certainty if it's a meningioma, or because some brain mets actually can go to the dura and look like a meningioma. And one of the things that I failed to mention earlier, which I was going to, is that one of the benefits of surgery is having a real diagnosis. A lot of times we assume with the radiation treatment that it is a meningioma, but if there's something that's unclear, the pathologist needs to see the tissue. I recently had a patient that was sent to me who was going blind and was having trouble moving his eye, something we called ophthalmoplegia, and he came with a diagnosis of a meningioma and was referred specifically for gamma knife. The difference in this patient is that his problems had progressed so fast. He was virtually normal 3 months ago, and by the time he saw me, he had very advanced vision loss and could not open his eyelid or move his eyeball at all. And so I was concerned this was not a meningioma. Meningiomas do not grow that fast, or it was a very malignant type. So even though it was in an area where the gamma knife was the treatment of choice, I did a biopsy, and in fact that patient turned out to have a squamous cell carcinoma, which is a type of cancer and very different and requires chemotherapy and everything different. So sometimes you do need to make that diagnosis, and I think if your mother with brain metastases has a few small tumors that look like meningiomas and she's in the gamma knife anyway, I would probably target it at the same time if it was safe. So again, thank you for your attention. I'm sorry we couldn't get to all of our questions. There's a lot I see, but you can go to the mhmni.com homepage. You can also look up Misher Neurosciences Institute, or you can also look up University of Texas Neurosurgery, and that'll have a link, and you can see this webinar. And if there's a question that is burning for you, we do have a mechanism for you to send emails, and usually it's not me, but somebody from our team will try to answer some of them. Thank you very much.